Muchas gracias a todos. Muy brevemente, la verdad es que agradezco mucho a todos y todas ustedes por la oportunidad de poder tener este encuentro que nos parece sumamente oportuno para poder intercambiar pues conocimientos con este tema de la pandemia. Como sabemos, pues el Seguro Social es la institución en nuestro país pues más importante y atendiendo todos estos temas que pues ya por todo un año han sido muy difíciles. Y Hadassah, que ha sido una luz en el camino en Israel, ha sido un pilar fundamental de todos los tratamientos y que en México ha sido muy cercano en todo lo que hemos podido hacer para poder pues intercambiar y conocer lo que se está haciendo bien allá y lo que, dadas las proporciones de nuestro país, se está haciendo, se ha hecho y se puede seguir haciendo en México. Si es que yo más que nada creo que lo importante es el intercambio entre el doctor y la parte médica, pero les agradezco mucho a todos. Mauricio, Comité Central, Hadassah, gente, todos del Seguro Social y amigos, que veo muchos que son muy cercanos al Seguro Social, amigos, pues adelante. Y gracias por la coordinación, Mauricio, de nuestro lado también. Así es que muchísimas gracias, Jim.
Bueno, creo que Marcos Chabot, presidente del Comité Central y de la Comunidad Judía de México, ¿querías decir unas palabras?
Sí, diré algo muy breve. Buenos días a todos. Boker Tov en Israel. En representación de la Comunidad Judía de México, quiero agradecer al Hospital Hadassah, Jule Saga, Jorge Diner, por la organización de esta plática con el doctor Mevorach, que nos va a compartir su experiencia y su conocimiento respecto al COVID-19 con el equipo médico del Instituto Mexicano del Seguro Social, que es la más grande e importante institución de salud en nuestro país. También quiero agradecer a Salomón Pressburger por ayudarnos con lo de este meeting, con esta reunión, y estamos seguros que va a ser un momento importante de aprender cómo Israel maneja el tema de la pandemia. Bueno, es un honor para la comunidad judía de servir de puente entre México e Israel, promover la comunicación, los intercambios científicos y los beneficios para que sea en beneficio de los dos países y especialmente durante estos tiempos difíciles. Entonces, gracias y gracias a todos.
Y unas palabras del doctor Mauricio Hernández, director de Prestaciones Económicas y Sociales del Instituto Mexicano del Seguro Social.
Mauricio aún no está, Salo, si quisieras dar pie.
Buenos días, hola el doctor David Barros del IMSS, representando al doctor Mauricio. Como bien mencionaron, se va a conectar en algunos minutos, probablemente pasada la media hora. Pero les quería agradecer mucho a todos por organizar, por prestar esta información. Estamos muy interesados, varios miembros de nuestra oficina de salud en el trabajo y muchas personas que están encargadas en el ejercicio de vacunación en el Estado de México. Y también me pidió, y el doctor Borja creo que también está, ya se ha conectado de parte de la Dirección de Prestaciones Médicas. Pues tenemos mucho interés en escuchar la presentación y pues muchas gracias.
Gracias a ustedes.
Buenos días. Muchas gracias.
And now I would like to introduce Professor Dror Mevorach, who will give us a presentation. And he is head of the internal medicine department in Hadassah Hospital. Professor Mevorach.
Buenos días a todos. But I will stop here with my Spanish, and I'm sorry, I'll speak in English or in Hebrew if you wish. I'm not sure what you would like to hear, but I will tell you a little bit about the COVID-19 in Israel. Let me see. Just 1 minute. I'll just share screen with you. Can you see it?
Yes.
Yes,
We
Doctor.
can see.
You see one or two? This
Two.
is better, no?
Yeah, that's better.
All right.
Thank you.
Okay, so actually, well, the history of the COVID, I think it is known worldwide, and it was found in December in China. And I must say that by January 10th, we already had the sequence of the virus published by the Chinese, which is important because it allowed the rapid development of vaccination, of detection kits, etc. We all understand that once the exponential growth factor is above 1, so we go up with the infection, and if it's below 1, we go down. And all our attempts in Israel, and I think worldwide, was to keep this R below 1. And the most popular way to do it in countries was with lockdown. However, I think Israel is a pioneer in the world that because it fights now the R with massive vaccination. And we have already now, by today, about more than 50% of the population that is vaccinated, and more than 80% of the 60 plus age people vaccinated. So there were different strains in the world, and the most known strain till November was this strain, which is called D614G, which dominated all the world. However, today in Israel, the most common one is the British mutation, and to a lesser extent, the South African mutation. So I don't want to bother you with the way the COVID-19 goes in. I will just perhaps go that you have an immune response to COVID, which is not only the antibodies that are produced, but it's also a cellular response, and that's why not always antibodies present a good and established response. And this is what happened when the viral load is in the body, and there is, first of all, a response of antibodies called IgA, and then IgM, and the most important is IgG that can actually protect from the virus. Now, you know that the severe can be mild or moderate or asymptomatic even, and can be severe illness. And we identify different risk factors for that. For instance, we, the males, are unfortunate in that regard. And if we are older, we are in a risk if we have cardiovascular diseases and or lung disease, diabetes, but also pregnancy for women. And unfortunately, the risk for pregnant women is twice as compared to their correlated age in women who are not pregnant. This is kind of description of what happened in the body, and there is the viral infection and the inflammatory side of it. And of course, all the treatments we have are related to the phase. Remdesivir is a treatment for the viral infection. Convalescent plasma or hyperimmune globulin or monoclonal antibodies are against the viral, whereas the inflammatory phase is by corticosteroids and also a medication that we developed at Hadassah, which is now going into phase 3 trial and was very successful in the phase 1 and 2. So this is the medications that we have today, either approved or that are in process of approval. You might see that we don't use hydroxychloroquine. I know it is popular in South America, at least in Brazil, I was told it is popular. However, we used it in April, May, but following new works, we decided to stop using it. And now I'm going to show you what happened at Hadassah. Hadassah Medical Center is actually the hospital that was with the more hospitalized patients in Corona in all the country. So you could see, I don't know if you read Hebrew, but this is the first wave. And you could see here every day how many patients were in hospital. You see the most were 94 in the first wave. And then there was a lockdown and it goes down. And then there was the second wave, which is up to 165. And there is the third wave that I will summarize in 2 weeks, which arrived to 145 patients. If you look, it's in Hebrew, I'm sorry, but I can tell you that we looked at the age groups. You see, you could see here the age group. You could see that 30% of the patients, or I would say 35% of the patients were below the age of 40. It's not only patients that are older, it is also a disease of younger patients, although people that are older get a more serious disease. And we had more men here in blue than women. And we had, of course, a lot of pregnant women. And you could see here the mortality rate that we had by the age group. And of course, the people that have the oldest people had the higher percentage of mortality, unfortunately. We could see it also in another way. You could see here that for people that were 90 or above, 38% unfortunately died. And if they were between 80 and 90, 26%. If they were 70 and 80, 16 or 17%. However, when you go to below 70, there is a sharp decline in mortality, like 6% and 3.2, and then it goes down to 0 almost in the very young population. However, it is important to mention here that if you look at people above 60, unfortunately, there were some population like the Orthodox Jews that died much more than the general population. This was because they live in a little bit more crowded fashion. Also, they were a little bit less prudent, and that was the result, unfortunately. So this is the survival curve. You could see the second wave was less death than the first wave. I won't bother you with all this. Just to tell you that very quickly we learned that people in the department of COVID-19 are lonely and they need help. And the medical staff, like a doctor like me, we could go in for a little bit and go out quite quickly. And the nurses, so they also were, it was difficult for them to work as they usually work, 8 hours, but they would enter for 2 hours, go out, 2 hours, go out, so the patients would stay alone. So what was here very nice is that a group of people was organized of people that were sick with COVID, and we started to put volunteers every day in the department of COVID that help the people. Now, these volunteers are from the Orthodox Jews in Jerusalem, but they helped everybody. They helped women, men, Jews, Arabs. They helped everybody, and this was very important. And you could see maybe that it's written here, Mitnadev, volunteer. These are two of the main organizers, and here I am with them in front of Hadassah Hospital in Jerusalem. I won't bother you maybe with that, but we characterize very nicely the level of cytokines, the storm, this inflammatory reaction of all patients. And we're able to show that it is, this is a table that shows correlation between different factors in the body and the clinical disease, which is manifested here with a criteria called NEWS2. And you could see that there was a very high correlation, which is in blue, to cytokines, different cytokines measured in these patients. And then we were able to treat them as necessary. So how do we treat today in Israel? Of course, the physical prevention is very important, the hygiene, the mask, the social distancing, the prevention by immunization. And you know that Israel, by now, 4.5 million out of 8.5 million were immunized with 1 shot and above 2 million with 2 shots. And this already is shown in the hospitals, that there is a decrease in the above 60 years hospitalization. There were some attempts to give post-exposure prophylaxis, but it didn't work very well in the world. So I don't know what vaccinations are available in Mexico, but in Israel we have the Pfizer and Moderna, the RNA immunization. We are going also to get some of the AstraZeneca, but there are also the Johnson & Johnson that were just introduced in South Africa recently, the Chinese and the Russian Sputnik 5. And there is also an Israeli immunization now in phase 2 already. And there are some more. There are over 200 companies that are trying to develop immunization, because you have to understand that immunization is not only the problem of Israel or the problem of Mexico, it's a problem worldwide. And for instance, I don't know the situation now in Mexico and vaccination, because some places in the world will get to vaccination only in a year time from now. And Israel was fortunate enough to get the vaccines quite early. So again, this is how we treat. And here I also added our in-house developed medication at Hadassah, the Alocetra, We gave it to 21 patients in critical and severe conditions, and 19 of the 21 left the hospital within a week healthy. So this looks very promising, and we are now preparing to conduct a phase 3 study. So maybe I suggest I'll stop here, and maybe you have some questions or discussion. I'll be very happy to learn from you about what's going on in Mexico. I'll be very happy to hear. And if there are questions, maybe Jean can moderate and let us know. Thank you very much.
Thank you. So if you have any questions, just unmute yourself, or just, yes, I see David Barros have a question, please.
Thank you. Yeah, thank you for the presentation, Professor Dror. I would love to dig a little bit deeper into your experience in the immunization. Particularly interested in how Israel allocated the vaccines, which groups were prioritized, and how was that conversation unfolding, and whether there were special groups of interest that were prioritized versus others. We're particularly interested in how immunization can be used to further the economic reactivation of the country. Is not one of the Mexican key criteria for allocation. We're mostly doing it by age, based on the principle of reducing mortality. But very interested in see how the economic dimension unfolds, and what was your experience there. And to kind of wrap that in, would love to hear just a little bit about your immunization criteria and what you learned from it. What would you do different, if you could? Thank you.
Yes, so we immunized first people that are above 60 and the medical staff. Now, this is one thing to say and another thing to do, because, for instance, there are houses of old people. So what do you do there? So it was clearly from the beginning that you can't vaccinate only the people above 60 in houses of old people, but you must actually vaccinate also the team that take care of them, because the team was actually the main reason for spreading of the disease. So this was actually understood very quickly, and the teams taking care of old people were also prioritized and got the vaccine quite quickly. Apart from these populations, we went down by the age gradually. And then in the midst of that, the teachers were prioritized. The teachers that are in schools that can, on one hand, spread, if they are sick, spread it to 30 students in their class, and these 30 students can spread it to their families. So it was clear that teachers should be also prioritized. They were not prioritized like the 60 years and above, but as a second or third class of priority. In Israel, we were lucky to have a very good system because we have the HMO, you know, the Kupat Cholim. I don't know if you're familiar with that, but this logistically enable us to spread the vaccination very quickly. For instance, if you go to Paris or to France, they don't have such a system, and the medical system there is built on private doctors. So they don't have good logistics for the mass vaccination. And they have also maybe some more people there with some resistance to vaccination, but also the logistics in France are not that good. And in that regard, you see that the vaccination process is only slowly progressing there. And in Israel, it was, it was more than 100,000 people a day, which is a lot for a country with 8 million people. So this is for your question.
Thank you.
All right, I see a raised hand. Vesta Richardson. Please unmute yourself. There.
Thank you, Professor. I was wondering if you could tell us the experience in Israel with children. Are the schools open? What about the daycare centers? Is the transmission rate high among children? In general, what the experience has been with under 5-year-olds?
So there is a very big dispute in that subject in Israel. There are half the people think one thing and half the people think the opposite. Maybe it's, I don't know, maybe it's typical in Israel, but in schools, it's very clear that we don't know what to do. And actually, Israel has a very negative achievement in regards to people not going to school. We have, I think, we are one of the first countries in the world that kept school closed. And many people think this was a mistake. However, it's clear that, for instance, when we opened schools after the second wave, it helped a lot to spread again the disease. So it's a question, and so we did it progressively. We are now doing it progressively. We start with the young children at the age of, the kindergarten, and then till the first or second grade. And after 2 weeks of these, we are opening to some more, like to the more, the other classes. And we progress, we hope to progress till full opening of schools. However, it is absolutely not, it's not possible to do it clearly because it's a problem. It's a problem, and on one hand, you can't keep the children at home all the time. On the other hand, you don't want to spread the disease. So how to do it wisely? Maybe Vesta, you could give us an advice.
Professor, all I can tell you is at our institution, we have 1,200 daycare centers, and they have been opening progressively in almost all the states. We still have 6 states that prefer to keep them closed, but children under 4 attend our daycare centers. And we have been monitoring the contagiousness both in the teachers and in the children. The experience has been very good with the children. A few of them, very few, have been, we're talking about more than 50,000 children attending the schools now. Only 20 cases that have been acquired in their families. But the problem has been the teachers, that they have community acquired disease. So it has been a good experience, and hopefully the schools for older children will also follow the age range and spread and open progressively. Primary schools are still closed.
Yes. So Vesta, thank you for this information. Maybe I can relate also to the question of Rodrigo Romero. And I ask you, what would you do in Mexico if some of your teachers will be against vaccination? And they are going to enter a class of 20 or 30 or sometimes even more children, but they are against vaccination. So in Israel, there is a big debate now, because on one hand, they say we cannot force them to vaccinate. We can recommend, but we cannot force them. On the other hand, they prepare some kind of measurements to ask teachers that are not willing to be vaccinated to check every 2 days PCR for coronavirus. Because if they want to teach, okay, if you don't want to vaccinate, okay, examined every day, which is not that pleasant for each person, every 2 days to examine. What would you do with teachers that are not willing to get vaccinated?
Well, I would probably suggest doing what we do with our teachers in the daycare centers. They have to comply with a very strict sanitary protocol. They have to wear masks and plastic covers over the visors and gloves. And I guess pretty soon, if they don't get vaccinated, fortunately, that is not a big problem in Mexico. Mexico has a very successful universal vaccination program, and 99% of the people run to get the vaccines. But tests are probably a good alternative if they don't want to get vaccinated.
All right,
Thank
so
you.
I guess we'll go to the next question. Manuel Carlos, por favor.
Sí, muchas gracias, profesor. Muchas gracias por esta información que nos da, y útil y nos ayuda justo a tomar decisiones. Y en ese sentido, lo que le quiero preguntar, profesor, nos decía usted que la población adulta mayor prácticamente en su gran mayoría está ya vacunada, y eso les ha permitido ir vacunando a personas cada vez más jóvenes. En este momento que están vacunando ya personas jóvenes, ¿han hecho alguna diferencia entre personas trabajadoras? ¿Le han dado alguna prioridad a las personas trabajadoras, o se han seguido moviendo solo por la edad, indistintamente que sea población económicamente activa o no?
Professor Mevorach, I don't know if you heard the translation. I can translate the question for you. If the question is if Israel prioritized the workers, the people who are working, or in general the population in terms of the vaccination. I think I got the question right.
Right, so they did not prioritize the workers. Actually, there is another discussion in Israel. I told you that we have a lot of discussions and disagreements, because now the workers, the commercial, are open after a lockdown. However, the schools are not yet open. So half of the people say, why do you open commerce before schools? And half the people say, well, yes, you have to open commerce before schools, because the people have to get some salaries, some money. But we don't prioritize people by working or not, but by age more.
All right, the next question I'm going to ask David to David Barros to unmute yourself.
Thank you, Jane. I think Javier had his hand up before me, so I'll happily.
All right. So Javier.
Thank you. Thank you. Nice presentation, Dr. Mevorach. I would like to ask you if you could elaborate a little bit more on the process that you're following on the convalescent plasma treatment. And also, it's a social question. What is the extent of the work which is being done by the volunteers in the hospitals? And you mentioned that they are persons which are or have been infected.
Yes. So maybe I start with the second question.
Professor Mevorach, if I just can add to Javier,
Sure.
I think they are excellent questions, both questions. I would like just to add, not just about the convalescent plasma, but also about the development of the treatment that Hadassah is doing, and it's getting into phase 3. Then I think we'll add that part completely. The volunteers and the convalescent and the Hadassah treatment, if you may.
All right. So about volunteers, we use them very much. They enter every day, and it is based on people that were sick. Now, maybe we could use also people that were vaccinated, but when we started it, there was no vaccination. So in order to protect them a little bit, we took only people that were sick. Although I must tell you, I entered many times the COVID area, and I was not neither vaccinated nor infected. But we can't ask from a volunteer to risk himself. So we asked the people to be only those who were sick and are somehow protected. This is a very nice project. As for convalescent plasma, there were some conflict findings about this treatment, and although in the FDA approved it in September in USA, even when it was approved, many people were resisting this authorization. They said it was a kind of political act by Trump. You know, even the scientific world was influenced by these questions. But I think now it is clear that I can tell you who I give convalescent plasma to. I give convalescent plasma to people that I am afraid won't be able to generate antibodies. These are people like hematologic diseases. I don't know if you're familiar with CLL and other diseases, or people that were treated with Maptera that reduces their B cells, so they cannot mount an immune response. So to these people, the minute they enter my department, I give them either convalescent plasma or monoclonal antibodies that have similar effects, like the Eli Lilly and the Regeneron, this cocktail that Trump got. And some Israeli companies also doing hyperimmune antibodies. So I give them to people that I'm afraid they won't be able to mount an antibody response. And our development, our drug, was meant mainly to the cytokine storm phase that not all the people develop, but those who develop it, many of them are either in severe or critical condition. So we actually, this is a cellular therapy, and we are injecting cells to the patient, cells that turn down the inflammation. And I think it was very good. There were very good results in the first 21 patients. And that's why we move now to a double-blind, placebo-controlled study.
Okay. Just one question. The convalescent plasma, you have a bank at the hospital?
Yes, we have both a bank at the hospital, but also we have kind of a general bank in Israel operated by what is called Magen David Adom. And so we have a national bank and a localized bank.
Okay. Thank you, Dr. Mevorach.
All right, so next, David, now you can ask your question. David.
Thank you very much, Jean, Professor. I have a few questions, but I'll start with one and then wait for my turn. To go back to Israel approach to reopening different activities, could you speak to a little bit more about what's the approach towards reopening universities? And is it different from schools? And what are you doing in terms of reopening universities?
Well, the university, well, I also in our hospital, we have the Hebrew University for the medical school. So actually all universities work by Zoom. No frontal lectures, etc. However, for the medical students, we now allowing them, the clinical medical student for the clinical studies, now we allow them to re-enter and participate in activities because they are all vaccinated, and we could allow that. But the general teaching in university till today in Israel is Zoom based, but in Israel, in the universities, as for other activities, there is a plan to do what is called a green, I would say, a green card, but not a green card like in the USA, but a green card that verify that you are vaccinated and you could enter a gathering of people. So you could, this is going to be applied also for the sports centers that were closed for many months, and also in the universities and other places. If you show your green card, meaning a card that shows that you were vaccinated, so you are able to participate.
Thank you, Professor.
Thank you. So now we have Jose Luis.
Maybe it's me. It's Jose David.
Muchas gracias,
Hello.
Soy José Luis
Thank
Carazo.
you. José Luis.
Gracias. Diciendo de aprovechar este conocimiento. Bueno, sí, gracias. Quisiera preguntarle, profesor, con todo respeto, de este doloroso tema para la comunidad mundial. Rescato como el más sólido de estos éxitos la recepción de un número elevado de vacunas. ¿A qué atribuyen ustedes ese éxito de tener tantas vacunas con respecto a los demás países que habitan este planeta? Muchas gracias por su respuesta.
So I'll translate the question. He's asking why do you think Israel had so much success in receiving so many vaccines in such a short time? Why do you think this success happened?
Well, I must tell you that in December, when we looked at other countries, we thought that we are not ready with the vaccines, because at the time that we started to negotiate seriously about vaccines, Canada, you know Canada, they had 6 or 7 times vaccine of their population. Europe had already, England had agreements with AstraZeneca and others of much more than Israel. But I think some people prepared the ground for vaccination by the Ministry of Health. And I think in December, more or less, maybe January, they really understood how important it is, and they accelerated negotiation. And actually, we were able to buy from Pfizer, and in Israel, everybody complained that we paid more for the vaccination of Pfizer than the European. But I think this was not that important to pay a little bit more. But I think Pfizer understood the potential of rapid vaccination in Israel, and they were interested to learn the effect. For instance, I can tell you that in my department, you see a decline in the hospital in the severe patients of the people above 60 as an effect of the vaccine. And Pfizer was very much interested to learn that. So they were willing to do deals with Israel. And since there were also negotiations with Moderna and AstraZeneca, so we ended with a number of vaccine which is above the population size. But I can tell you that Canada, as I told you, had 5 times from the population size, and even more, even in December. So they were even more preparing. If we want to learn to think ahead, I think the Canadian did it very well. How is the situation in Mexico with vaccination? Do you have enough vaccines?
I don't know who wants to answer this question very quickly. Vesta?
Yes.
Oh, go ahead, Vesta, if you want.
Well,
yo hice la pregunta, si gusta la respondo. En realidad en México hasta hoy hemos recibido un 1% de lo que representa la población abierta. Es decir, 1.700.000 vacunas, teniendo una población de 130 millones de habitantes, 127 millones de habitantes. Todo Latinoamérica en general toda Latinoamérica tiene 12 millones de vacunas recibidos. Y hay países como Perú que solo ha recibido 343. El caso más elevado que se tiene en Latinoamérica es Chile, con 2,5 millones aproximadamente de vacunas. Pero estamos muy reducidos en Latinoamérica.
All right, thank you. We're going to have...
Also, you know, you have cheaper vaccines, I think, in the Russian and even AstraZeneca. And I don't know about the Chinese, but why is it so? Is it because of costs? Is it because of organization? It's not possible to accelerate it somehow?
Yeah, thank you for the question. I think, well, we have an agreement for a total of, I believe, 105 million people vaccinated, which is somewhat to 180 million doses. The problem is the sequencing of that access of the vaccines. Similar to other countries, it's unclear, even in discussions, as far as I'm aware, with the providers, when and how many are going to be delivered. It's being kept on a very tight leash in terms of that information. We have planned, at least in terms of a contractual agreement and in terms of what the federal government has published, the calendar for the delivery of the vaccines, to have that amount of vaccines, that those 180 million vaccines delivered in 2021, but that remains to be seen. We're already delayed as it is right now. We have, as it was mentioned, we have administered 1.7 million doses. I think that data point is updated to yesterday. So it's a question of access and sequencing of access. So that's where we're at. And as you said, this is actually, I'll take my place. I have a question related to this, but maybe Jose David Mendez, I know he has a question waiting as well. But I hopefully that answered the question.
Thank you. I guess Jose Mendez, you've been waiting to ask your question.
Yes, thank you, Jenna. Thank you, Professor. I have a question. Professor, is COVID considered an occupational disease in Israel, especially for healthcare workers?
How did you define it? Professional disease?
Yeah, occupational disease.
Occupational disease?
Yeah.
I have no idea. I must tell you, we didn't think about it. We just worked in the hospitals and, you know, there was a need, we worked. I don't know about definitions, but I think you're right that people have to give a thought to that and see how to define it and etc. for teachers, for health workers, for others. But we didn't go into that. I must tell you, we just had to fight the disease. And I must tell you that even in Israel, that we have a good medical system, there were moments that it was very difficult to give a good medical treatment to all patients.
Okay, thank you, Doctor.
All right, so the time is running out, but I see we still have a couple of questions. So maybe if we can do quick questions, we'll be able to do both of them. David?
Thank you. In part, I want to answer a little bit on the status of Mexico. As you know, as in many countries, we have had access in terms of Pfizer vaccines, AstraZeneca, recently Sinovac from China, and Sputnik. The question related to you is if you run into issues in terms of which vaccine should be delivered to what population, and what decisions did you take based on the of the one dosage versus two dosage differences, or others related to cold chain?
Well, that's a very good question, and I think people think that when you need a mass vaccination in villages and other places that are remote, it's better to use one vaccine, one shot, and not two shots that are maybe a privilege of people in towns, in areas, in cities, etc. The other thing is, of course, the efficacy and effectiveness of the vaccines. And I think what I read in the Lancet for the Russian vaccine, it looks good. And the Chinese, I have less knowledge. But I think if the vaccines are good, one shot should be preferred in remote areas, and two shots in areas that are more rural and with possibility to be approached, provided they are more or less equal. We heard, for instance, that the AstraZeneca perhaps is less effective against the South African mutation. Now, don't buy it yet. It was in a very small group. But if this is the case, we all have to consider, of course, in which vaccine to use if one is not effective for a mutation, a certain mutation.
Professor, I would just make, before the last question that Jim will take, if you can talk a little bit about the Israeli vaccine that you are working very hard on it in Israel, on the biological, and it might be interesting for Mexico or for the Instituto Mexicano del Seguro Social at some point, because I think that vaccine could be ready when we will be needing it in Mexico, and maybe the IMSS could be a bridge also to help into those trials and maybe have it, if that's a need in Mexico and Mexico needs it, would be of help.
Right. So this is a traditional vaccine using the VSV virus. And in that regard, it's similar to the AstraZeneca or to the Russian, although the virus is a little bit the inactivated virus in there, but here it is a normal virus, but that affects animals and not human, so it's considered quite safe. And I think it can be used very nicely worldwide, but we are not yet there because we didn't start the phase 3, so it might take at least a few months till we are able to see if this vaccine is working or not. And of course, we have to be very careful not to give vaccines that are not working. So it will take a little bit time.
Yo una pregunta muy rápida, perdón. Ante la escasez de las vacunas que estamos teniendo, esperar a que la fase 3 puede ser más riesgoso a darlas en fase 2, las vacunas, ¿qué es más riesgoso, no darlas o darlas antes de terminar la fase 3?
I don't know if you heard the translation. The question was what, according to the vaccine, regarding the vaccine, what is the most risky, not giving the vaccine at all or giving a vaccine that is in phase 2 and didn't get to phase 3?
I won't give phase 2 vaccines to people. I think we can accelerate the regulation. We can accelerate the regulation, but I don't think we should give it without phase 3, but we could accelerate the regulation. And also there are the Chinese, the Russian, which are probably after phase 3, according to the reports. But I am against using phase 2 vaccines in the population.
All right, I think the last question is from Vesta.
Yes, thank you. Most of my other questions were already answered, but are you doing or are you planning on measuring IgG antibody levels and the duration of these levels depending on the type of vaccine, or are you not worried about different efficacy and long-term efficacy?
Right. So I am an immunologist also by training, and I can tell you that the efficacy of vaccine is not only the antibodies. It is also the generation of what is called memory B cells and also effective T cells. And we can measure these things. However, it is sophisticated. I can measure it in my lab, but it is not a routine measurement of the hospital or the Ministry of Health. So I'm not sure what it will bring. Of course, you want to see how long the immune response lasts. And today we think it will last at least 1 year. And if we see a little bit of decline in the level of antibodies, it doesn't say it is natural. And it doesn't say that you don't have an immune response. Because when you see the virus, you will have very fast response by the memory, B cells, etc. So it's good to measure, I think, and many groups are measuring it, but hopefully we will learn from other people that started it even before us.
Thank you very much. I think we're gonna end the questions here and conclude. Thank you, Professor Mevorach, for your time. there's going to be a few words of conclusion. You can turn your translation on at the bottom. And I'm going to give the microphone to Salomon Presberger. Por
Muchas
favor.
gracias. Sí, muchas gracias. Nada más agradecer a todos los que tuvieron algo que ver en organizar este Zoom. Creo que es el primer contacto. Es muy importante lo que hemos hecho. Las culturas entre México y Estados Unidos son muy distintas. Las capacidades también son muy distintas. Entonces yo espero que continuemos y logremos hacer algo muy importante y que beneficie a ambos países y a ambas instituciones. Muchas gracias a todos.
Y ahora voy a dar la palabra a Jorge Diner, el director ejecutivo de Hadassah Internacional.
Muchas gracias, Chan. Creo que es difícil a veces poder entender el mundo en el que estamos viviendo. Por un lado tenemos algo que unió a todo el mundo muy rápidamente, que es un virus, y que nos da la sensación de que estemos donde estemos, pertenezcamos al país que pertenezcamos, países pobres, países ricos, en cualquier lugar del mundo y en cualquier continente, todos estamos unidos bajo un mismo fenómeno que es el virus. Pero en realidad lo que se ve, y se ve quizás más claro que nunca, en el segundo año de la pandemia, que es el año de la vacunación, es el año de empezar a encontrar la salida, las diferencias que existen en el mundo antes de la pandemia salen a la luz en el momento en el que hay una diferencia muy grande, en tanto como algunos de ustedes también comentaron, tanto en el acceso como a las vacunas, como la capacidad también logística. A veces las diferencias no solamente son entre países ricos y pobres, creo que lo explicó muy bien el profesor Mevorach, cuando hizo la comparación entre Israel y Francia. Francia es un país desarrollado, pero que tiene un sistema de salud pública que está basado en reembolsos a médicos privados y no en una estructura de salud pública que permita una solución a una epidemia como sí tiene Israel, que desde Hadassah se creó hace décadas un sistema que hoy en día es el sistema en Israel, que es un sistema de salud pública que es universal y masivo y de acceso público de una forma muy organizada que permite montar de un día para el otro, no solamente que lleguen una cantidad de vacunas, sino que el tiempo entre que las vacunas están disponibles y que le llegan al brazo de las personas que pueden ser vacunadas según los criterios, el tiempo es mínimo porque la logística es prácticamente, no vamos a decir que es tocar un botón y que funcione, pero está montada previamente porque es la forma que en el día a día funciona el sistema de salud. Pero las diferencias creo que son importantes y creo que cuando el profesor Mevorach preguntaba cómo es la situación en México, desde el lugar en el que yo trabajo como director internacional y teniendo México como uno de mis centros más importantes de actividad, conociendo bastante bien la situación en México, las diferencias son muy grandes, pero los puentes como el que hemos levantado hoy con este encuentro son los que pueden aliviar, los que pueden ayudar, los que pueden traer soluciones. Los tiempos de vacunación en Israel son extraordinarios porque es un país pequeño, porque es un país no solamente desarrollado, sino un país que es desarrollado en la salud pública, como dije antes, en uno de los modelos que sea de salud pública no perfectos, pero mejores en lo que garantiza la efectividad del sistema. Y en ese sentido, un puente como este puede permitir ayudar en los tiempos que son diferentes. El virus no se va a ir en 2 meses, no se va a ir en 3, no se va a ir en 6, irá variando, irá mutando. No necesitamos una dosis de vacunas, probablemente en el mundo necesite varios ciclos de vacunas, con lo cual cuando hablamos de que si el desarrollo de una vacuna en Israel estará aprobado dentro de 6 meses, bueno, dentro de 6 meses o se necesitará todavía en muchos lugares la primera vacuna o la que viene después, la que sea la segunda, o la que sea para la segunda vuelta. Son muchas vacunas que el mundo necesita para poder estar inmunizado y lograr la inmunidad de rebaño no solo local en un país, sino también a nivel global. Pero hasta que se llegue a ese punto, también los tratamientos, la logística, el manejo de la pandemia, la administración de las soluciones, son los que siguen siendo importantes, porque va a llevar todavía un tiempo largo, por lo menos un año más o más, que el mundo pueda estar inmunizado. Y en ese sentido creo que como dije hace un minuto, el puente que se puede generar entre las experiencias. Fíjense que la experiencia que ustedes compartían de los niños, es una experiencia que es muy valiosa para Israel, donde ha sido un desafío muy grande todo el tiempo. Quiere decir que este es un puente de 2 vías, donde se comparte información, donde se comparte conocimiento, experiencia que puede traer soluciones, donde somos todos pares, con diferentes contextos y diferentes situaciones, dejando fuera la política, la colaboración científica, profesional, voluntaria, liderazgo, empresario, sociedad civil, para construir puentes que generen soluciones hoy en día a la gente, y que al final lo que consiguen es salvar una vida, como está escrito en el Talmud: quien salva una vida es como si salvara toda la humanidad, y poder tener, si este diálogo puede generar que eso pase en un lado o en el otro, quizás en algún otro lugar donde se genere conocimiento, valió la pena. Quiero agradecer mucho al Comité Central de la Comunidad Judía de México, que generó esta oportunidad conversando con nosotros en Hadassah, Marco Chabot, Mauricio Lurca, a el Board de Hadassah México, Fulesaga, Ethel Feinstein, que generaron, y todo el resto de los miembros que generaron esto, y por supuesto, y voy a pasar directamente a inglés. I want to thank, I don't know if it's still in the translation, I want to thank Professor Mevorach. You have to know Professor Mevorach is not just an eminence in Hadassah, he's an eminence in Israel today. Is one of the most respected leaders of this crisis in Israel, not only wearing his hat, el sombrero as a medical professional, but also as a leader, you know, on many issues, on motivating people. Follow him on Twitter. It's in Hebrew, so you might need to use Google Translate. His Twitter is probably one of the most followed Twitters for people, because it's not only about getting information, it's about the motivation, the hope that, you know, when it comes from an authority that is working every day inside the COVID-19 unit, and at the same time working every day in the labs that are developing the drugs that will help not only people in Israel but all over the world. This is I think this is an example for what we were saying, you know. One of the things that I like about Professor Mevorach, which I think is a symbol of many other people in Hadassah, but in this moment he's at the front line, is when there was some question about something, he said, I don't know the answer. We are just doing. We are just working and doing, and it's really the modus operandi. Así que muchas gracias, Professor Mevorach. Thank you very much. Y el puente está abierto entre Hadassah y el IMSS para que durante todo el tiempo que tengamos que seguir durante esta crisis podamos seguir consultando, y después que podamos seguir colaborando también en todas áreas en lo que podamos también ayudar a México. Hadassah como organización se creó hace 100 años con una misión humanitaria de traer salud al mundo, no solamente de curar pacientes en Jerusalén. Y en eso es lo que estamos, es nuestra misión, y esto es parte de ese universo. Así que muchas gracias, hasta la próxima.
Gracias, Jorge. Gracias a todos. Gracias, profesor. Shalom.
Gracias a todos, Rabá.
Muchas gracias.
Muchas gracias a todos. Muy buen día.
Muchas gracias, Salomón.
Muchas gracias. Gracias a todos. Muchas gracias. Gracias, Salomón.
Gracias. Muchas gracias.
Muchas gracias, consejeros.
A ustedes, gracias.
Gracias a todos.
Gracias a
todos.